medicine is a long journey. And you are in it for the long run. It's whatever you do is going to take you way more than a decade to be a consultant. In England, 90% things are similar. They are quite protocol driven. In India, things can vary a lot. Amount of standardization in every state or every city is not the same. Make your vocation your vacation. If you are a person who wants quick results, then I don't think medicine is kind of the thing for you. You are in it for the long haul. It's going to be much beyond a decade. Medicine is a good, noble profession. When you do medicine, you do it with a view to improving everyone's health. Being a doctor is a good thing for society. You're doing some good to people. The research can delay things by 2 to 3 years. It's not necessarily a delay. It's just like getting this experience.
Hello and welcome to another episode of Social Untold. Today we have Dr. Anand Singh again with us. Welcome back, sir.
Thank you.
He is a consultant respiratory, physician, and he's working with West Hertfordshire NHS Trust, and he's also working with quite a few other private hospitals and clinics. Let's hear it from him, please.
Thank you, Zoeb. So thank you for inviting me again. And so I practice as a respiratory consultant at West Hertfordshire NHS Trust. I also work privately at Clementine Churchill Hospital in Harrow, Scion Clinic in West London, Brentford, and One Stop Doctors in Hertfordshire. It's indeed an honor to be here today to talk on the subject of medical education and career pathways.
Thank you. So, as Dr. Anand already mentioned, what we are talking about today is going to be for new generation, people who are aspiring doctors, who are in the process of their education. What are the pathways for them to come and work over in UK? What are the better options for them? And what is the most optimum or the quickest way of working and practicing in UK or anywhere overseas, if they're coming from India, Pakistan, any South Asian country, any other countries. So, let's start, sir. Starting with the systems. You've practiced in India, you've practiced in UK both.
Yes.
What do you feel the differences are in the system, in the process of becoming a doctor or a consultant in UK and India? What are the differences or the key differences?
So it's an interesting question. I mean, I would analyze from my practice, having worked in India and Mumbai and worked in England in various places, including London. So I would say that the system in England is a little much more standardized. That in England, when you are working, say for example in London, if you go to Wales or Scotland, 90% things are similar. They are quite protocol driven, like the treatment pathways, for example, for sepsis or for a particular condition is more than 90 to 95% same. There are very subtle nuances or variations at a local institutional level or at a city-based level based on some protocols they follow. But by and large, it's quite similar. I would say in India, things can vary a lot. The amount of standardization in every state or every city is not the same. There can be more variation, and that can sometimes be a good thing. Everything has its pros and cons. For example, in England, the education is going to be in English. The protocols are going to be standardized. There are, for example, if you're a physician, you're going to follow Royal College of Physician protocols. You're going to study the protocols set by NICE, the National Institute of Clinical Excellence. If you're a surgeon, you're going to follow the Royal College of Surgeon protocols. So, there is a significant benchmark which people follow, which makes things standardized. What happens in India is the education can be very good, but it is a bit more variable between different institutes and different states and cities.
Okay, so let's talk about the education. When we talk about the education, what is the route in India? How long does it take? And I'm guessing it's pretty similar in Pakistan as well. The time it takes a student from leaving the medical or leaving what's it called, 12th grade or A levels, and then that pathway and the similar pathway in UK. What are the differences?
Okay, so first of all, like a word of advice or, to the next generation or to aspiring doctors or to medical students that, medicine is a long journey. and you are in it for the long run. So you have to enjoy what you do and be positive about it. It's not a sprint race. You're not going to sprint through it. It's too long. It's whatever you do is going to take you way more than a decade to be a consultant. And I think you have to have that patience and understanding. If you are doing medicine or if you are aspiring to do medicine, I think you have to understand that this career choice is something quite different to your colleagues. If you look at your colleagues who are doing finance, architecture, or other kind of business management or so, your education is going to be longer than them. It's going to be quite long. So you have to be patient. To succeed, you also require different qualities, of good communication, human interaction at a personal level. I think, of course, everyone should be good in these things, but I would just like to re-emphasize that, you're in it for the long haul. It's going to be much beyond a decade from the time that you start studying till the time that you specialize, and it's a long journey. So you have to be patient. And I think the quest of wanting to do medicine is about being a good human being a good communicator, empathetic. Of course, you need the technical skills. Definitely, you need technical skills. If you're a surgeon, you need surgical skills. If you are an endoscopist, a physician doing procedures, of course, you need the technical skill set to do the relevant procedures in your specialty, whether it's endoscopy, whether you're a cardiologist who wants to do cardiac catheterization. Of course, these skills are important, but you should be a good empathetic, caring human being, good in communication, good technical skills. And I think your aim should always be to, heal someone by the way that you have a caring nature and explain things and be empathetic in your response. I think these are inbuilt criteria that are important to succeed. And somehow I think, with the current focus being so much on AI and technology, I mean, don't get me wrong, these are important things. Of course, we have to use the diagnostic tests and the advances in technology to our benefit, but this shouldn't replace our communication skills.
Absolutely. Okay. So going back to the question was the duration it takes.
So the duration, I'll put in India, people first do MBBS. I think it's around 4.5 years, followed by 1 year of internship. So that's 5.5 years at least. After this, there's a very competitive process where the doctors have to sit for entrance exams like the National Eligibility Entrance Test to do MD or MS. They have DNB entrance exams, which can be an alternative. These are very competitive. I mean, broadly speaking, again, I speak from personal experience, which is a long time ago, but by and large, the exams are very competitive because there are people like over 1 lakh or over hundreds of thousands of people, at least 80 to 100,000 people giving the exam, and there are a few thousand seats. So it is a very competitive process, no doubt, and not everybody gets seats. And there are sometimes people who repeat their attempts in the next year or the next to next year as well, so that they have had more time to prepare. So it makes it difficult and challenging. It is a very competitive process. And yes, when the student gets a particular rank in the entrance exam, then the allocation is done based on their preference for the location and based on their specialty. And based on that, they can get allocated a seat. Conventionally, there used to be MD and MS, but in the last 10 to 15 years, DNB is another form of post-graduation. It is equivalent to MD or MS. It is just a different degree. And DNB is awarded by the National Board, which is in New Delhi. MD and MS usually can be awarded by a state level university. I mean, for practical purposes, they are the same when you practice in India, but these are the different ways. So if there are some branches for which there is specialization, like a 3-year MD or a 3-year MS, followed by super specialization. And there are some branches for which the 3-year specialization is a terminal branch. Okay. So to put that into context, a branch like dermatology, MD dermatology or DNB dermatology makes you a specialist after 3 years. Whereas if you do an MD in general medicine or an MS in general surgery, you then have an option to pursue a DM, which is super specialization in, suppose MD medicine in India can then do DM cardiology or neurology or gastroenterology or cardiology or hematology or oncology. Likewise, MS general surgeon can do various subspecialty, super specialized surgical training in MCH like neurosurgery, pediatric surgery, thoracic surgery, cardiothoracic surgery, various types of surgery. So whereas orthopedics MS would be more of a terminal branch. And of course, things are changing. In the current times, everybody has an area of interest, and most people, even if they do a terminal branch, like say for example, they finish their MD or MS and they don't have an opportunity for DM or MCH, then they land up doing fellowships, sometimes in India, sometimes in excellent apex institutes in India, sometimes they go abroad to get certain different systems exposure, be focused in one or two particular subspecialties or certain procedural skills which they want to enhance.
Okay. So how does that process compare to?
Correct. So that's 5.5 years of MBBS plus 3 years of specialization. That's assuming one gets into that entrance exam in the first go, then that's 8.5 years. But various states, when you do MD or MS, sometimes certain states in India, they require you, they have something called as a government bond, meaning once you do your post-graduation, they require you to work in that state for 1 or 2 years. This again, conditions apply. Every state has different rules. So the reality is it can add 1 to 2 years to your education because you have to work them. You do get salary for that. But basically they want to ensure that the doctors work in that state, in that hospital or adjacent hospitals to look after the patients for some time. So the minimum we are looking at is 8.5 years plus if there is any what you call as postgraduate bond to be served. And this is assuming the student cracks the entrance exam for MBBS and post-graduation in the first go, which is a very tall order, to be honest. Realistically, most people would need like at least one more attempt at it. But again, this is the bare minimum. If one were to do a branch like say MD general medicine or MS general surgery, and then they wish to do a DM cardiology or say a MCH in cardiothoracic surgery, that would add another 3 to 4 years to the process because they would have to give another entrance exam after their MD or MS. And if they get a rank, then they would need to spend another 3 years for that. And then again, depending on the institute and the state rules in India, they may have to serve for 1 year as part of the government bond. So that would then make it about 12 to 13 years if they chose such a branch. So the answer to your question, yes, the minimum would be like 9 years. It could be up to 12 to 13 years, including somebody who does super specialization with DM or MCH. But this is assuming a rosy picture that this is a student who gets through everything in the first attempt, including the daunting entrance exams. Whereas it may not be for everyone that this happens in the first attempt.
Okay. And the process in UK, is that similar or is it shorter?
The process in UK is also long. I mean, in UK, again, the MBBS is again 4 to 5 years. Now they are coming up with slightly different courses which are changing and they are announcing slightly shortened courses. But then the student has to have done certain different graduations, certain qualifications after their A-levels before they enter medicine, and they may possibly have a shorter duration. These courses are being worked out, but conventionally, yes, the MBBS duration is similar. After doing their MBBS, they have 2 years of foundation training. That's foundation year 1 and foundation year 2. So the end of foundation year 2 is sort of equivalent to the end of internship in India, broadly speaking. Then after the foundation year 2 commences, conventionally the options have been to do medical training, like somebody who wants to do medicine, or they could do surgical training, or if they want to do anesthetics. These are broadly speaking been the options. Again, you have various subspecialties of medicine, surgery and anesthetics. Usually speaking, the specialty training takes around 7 years. Around 7 years. So if one, after the internship completing, it's at least 7 to 8 years. Because when you start, it used to be called core medical training and core surgical training. Now the word is internal medicine training. So I'm speaking as a physician, I'm a respiratory and sleep consultant. So I speak more as a physician, but broadly speaking, this does apply to surgical specialties and anesthetics as well. So say if you want to be a physician, after doing your MBBS and finishing your foundation year training, there is 3 years of IMT or internal medicine training. Following this, there is specialty training where you start from ST4 till ST7. So that's another 4 years. And that, for example, if you want to do respiratory, cardiology, neurology, gastroenterology. So this is the pathway. This is 7 years. Again, this 7 years is assuming that one works full time, one gets all the requirement outcomes every year, to make sure the Royal College and the university grants them the achieve standard for every year. They pass all the relevant exams, they work full time, they don't take a career gap. If one intends to take a career break, which many people do these days, so as a consultant, I do have students. I am an education supervisor and I have students who work under me, and I am a supervisor for them. So I do see sometimes they don't want to take a career gap. Sometimes the doctors want to do less than full-time work, which is an option. And for those who want to have flexibility, I think the system in England does allow that. To the best of my knowledge, based on my time when I trained in India, of course, that it's not very easy to have these flexible systems in India. In England, you can have part-time training. For some people, work 60% or 80%. It's not just about maternity care or so. Sometimes there are people by choice who wish to work less than full-time because they wish to have a better work-life balance, or they wish to explore other things, and they may have some interest which lies beyond medicine. And fair enough. And the other thing is sometimes people wish to do research. So if they wish to do research in between, it depends on what type of research they are doing, whether it's a research project, is it a MD research project, is it a PhD research project. Sometimes the research MD or PhD can be for 2 to 3 years. And sometimes it can even last longer depending on where the research project takes them. So when we spoke about 5 years plus 7 years, that's 12 years for being a specialist here. And this assumes that you clear all your exams, you get allocated the specialty of your choice in a place of your choice in the first attempt, which again is challenging. I mean, I once had a nice junior or a nice resident doctor working under me, and in a hospital in London, and he was very clear to me, Dr Singh, I can't go outside London. My brain doesn't work outside London. I've spent my whole life in London. I'll change my speciality, but I'll work in London. I'm not going to go outside London. Wow. And he did get into specialization training in London, but fortunately it worked out for him. But again, different people have different objectives. Another colleague of his might have wished to stick to their speciality, and they may have wished to go outside to a different city. And again, like we said, the research can delay things by 2 to 3 years. It's not necessarily a delay. It's just like, getting this experience, because once you finish your training, it's unlikely at a later stage you're going to experience these things. And sometimes people also go for an OOP, meaning an out of program experience. Now, the good thing with England's system is that these are formalized. The university and the deanery generally do allow, within reasonable limits, if there is a good program or a reason, they allow you to take an out of program experience. Okay. But of course, they do make it clear that the out of program experience is not going to be counted as part of your training. For example, if somebody sees an opportunity to be involved in a research project or some type of specialty where they are running trials and there may be a scope to do some publications and research, they can take permission from the university and the deanery to go out of program, to pause their training for a period of say 1 year or 2 years, complete that and then come back. Okay. This can be permitted, but it has to be done via the correct official channels. Obviously, that will extend the duration of training. And like we discussed, if one goes part-time, then it is possible, but again, it extends the duration of training. If somebody works 60%, then they will probably take 5 years to complete what could have been done in 3 years. And if one works 80% of full-time, then they will take 4 years to complete what could have been done in 3 years. So these are possibilities, and that will extend things. And nowadays, some doctors like to take a gap year. I do see a lot of resident doctors wanting to take a gap year, and they wish to go abroad or take a break for 6 months to catch up on different things before they get into the long, grueling training. And that's a choice. And the good thing about England is that this is something that is accepted, in the sense that this may not be very standardized. I mean, there is no right and wrong. I think in India, as parents, we are very focused. You want the kids to be, focused on studies and in a very focused way, where a path is being set in a clear way. Whereas here, things are a little more flexible. And that can be a good thing if someone is looking to take out a career break. Or nowadays, a lot of doctors tend to do after finishing their foundation year training, they tend to locum, or they tend to work as a locum doctor, meaning they pick up shifts where they don't get into training, and they do that for a period for a year or two. They do this, well, it allows them to understand which branches they like and which branches they dislike. It also allows a bit of flexibility in terms of they choose to work when they want, and sometimes it can allow better pay.
Sure. So that's clarified that really. In terms of people or medical students who are aspiring to do their studies, something like what you've done in India, and then or Pakistan, and then travel over to UK, and then so what is the process for them? What is the optimum route for them? I mean, there are things like PLAB, there are other pathways available.
So first and foremost, if you are a doctor overseas, like say if you're a doctor in India or abroad, to come to England, you need license to practice. Just like, for example, in India, you have Medical Council of India, or say in Maharashtra, you have the Maharashtra Medical Council. In UK, you have the GMC, which is called as the General Medical Council. So it is the professional body which regulates all doctors in England and Wales. So you need to get registered with the General Medical Council. Now, if you want to get registered with the General Medical Council, there are different ways to get this. This depends on the individual doctor's qualifications, skill, and the stage of their career.
Okay.
One pathway is that for doctors who have finished MBBS, they can give the PLAB exams. After they clear the PLAB exams, they get license to practice if they are registered with the GMC. But they have to clear all the steps of the PLAB exam. Another way is if they have cleared what is called as an acceptable postgraduate qualification. Now, although it is called postgraduate qualification, it doesn't make you a consultant in England. It is just it is a terminology. For example, if a physician in India does MRCP and clears all the parts of it, meaning part 1 written, part 2 written, and the clinical PACES exam, then after they get the MRCP degree, they need to get that registered, and with this they can get General Medical Council registration. Likewise, for surgeons, there is a MRCS exam, and there are certain other specialty surgical exams that can give General Medical Council registration if they are in the acceptable list of General Medical Council postgraduate qualifications.
Okay.
So like this, there are certain postgraduate qualifications for anesthetist doctors as well, which can give them GMC. This is a dynamic process, and this can keep changing. So for further information, you should check the General Medical Council website about the list of acceptable postgraduate qualifications, as I'm sure they update their details based on the changes. Another way can be to get sponsorship for registration, and this is generally done by the Royal College of Physicians, Royal College of Surgeons. There is a program called MTI, or Medical Training Initiative, which is a program by which the hospitals in England can recruit international medical graduates for a period of up to 2 years on a visa, and on the medical council registration, which is recommended and sponsored by the Royal College. So again, this is another possibility, but obviously there is a lot of details that one has to go through and a lot of conditions that need to be fulfilled for this. These details can be found if you look at, Medical Training Initiative, Royal College of Physicians. So this is more for physicians. There are some MTI, Medical Training Initiative programs for surgeons as well, and you would have to look out for this online on the Royal College of Surgeons website.
Okay.
So these are, broadly speaking, the 3 ways. One was the licensing exam PLAB. The second is the acceptable postgraduate qualification. And the third is sponsorship of medical council registration through the Royal College sponsoring it. But of course, one would need to secure a kind of work permit or a visa for a job to come here. It's not just about the medical council registration.
Now, for you, in your experience, which is the most optimum way and your recommended way from your side? I mean, this is your opinion, obviously.
I think there's no optimal. I think it depends on the individual levels, individual doctor's qualification and skill and experience. For example, if someone has just finished their MBBS, then it is an option to, if they are able to clear PLAB, then it can be an option to come here. But if someone is in the middle of doing their post-graduation or specialization, then it obviously makes sense to finish that. It doesn't make sense to just leave that. They should complete that post-graduation in India, if they are doing it, complete their MD or MS, and then try to get the acceptable postgraduate qualifications or sponsorship to Royal College and then come. So the answer is based on the stage of their career. And also there are various, recruitment drives. Sometimes the Royal College of Physicians does tend to go and visit India, I think roughly once a year, for recruitment, conducting interviews for the medical training initiative as well. So, keep an eye out for these things. If you search online medical training initiative, you will find the details of how to apply for these things.
Okay. Now, there's also an entrance process called NEET.
Yeah.
Now, in comparison with PLAB and NEET and what is the other one, MRCP?
Yeah.
So, which one is the toughest and which one is the easiest?
Okay. I think this is a difficult one. I mean, I've given most of these exams. I haven't given PLAB, but I've given MRCP, I've given the NEET. So in India, the entrance exams, like I said, numerically, they are quite competitive, because for the postgraduate entrance exam in India, I think roughly speaking, there are maybe 80 to 100,000 doctors who give the exam, and there are few thousand seats. So it is very competitive, because only a small proportion of people actually get a postgraduate or a specialization training seat. And for undergraduation, again, it's quite competitive, because I think the ratio of the people who appear to the number of seats available is actually significant. So it makes it quite difficult. In England also, it is very competitive, but I think it's not based on an entrance exam. The entrance to MBBS is based on their score, in the university results. It is based on work experience, interview performance, university results. I think their way of assessing it is a little bit more diverse, rather than looking at one entrance exam result. So it's a different way of measuring it.
Okay.
And people try to always get their work experience done. They try to get different experiences, research projects, different educational backgrounds to, add different things to their CV to get in.
So now, for somebody who's preparing for these exams, any one of these exams, what would your advice be? What kind of mindset, how should they approach these exams to give themselves the best chance? But we understand it's competitive. There are loads of people doing it. So what can they do to give themselves a best chance?
I mean, I think success is based on, motivation and inspiration besides the effort as well. I think I think to succeed, you have to look at your long-term goals in life. And I feel that, like, it comes back to my philosophy, where I say that medicine is a journey. It's not a sprint race. If you have decided if you want to do medicine, or if you are already doing medicine, I think you have to understand that this is a long journey. Like we discussed, in the best case scenario, it's going to take 12 to 13 years to be a specialist. It could even be longer, depending on whether you work full-time, research. And, even if you don't get the specialty of your choice or the location of your choice in the first go, it adds some time, but it's not the end of the world. You can try again. You can try again. You can see if you match into a specialty or place of your choice. So I think it is about thinking things through philosophically, that understanding that it requires patience. It requires you to be a positive, empathetic, caring person. And of course, you require, technical skills, and I'm sure you're going to acquire that in the course of your training. But let's not forget that one has to have that understanding that, medicine is a journey. It's not a sprint race. And I think you should not compare to your colleagues or your school friends or your college peers who are studying different aspects of life. Because obviously it's good. Their education is going to be shorter, and they're going to finish quicker than you, and they'll probably be doing jobs and working while you are studying. And I've experienced that, but it's part of life. So it is about setting realistic expectations. And the other thing is, if you want inspiration, doing medicine is something which, you should think of. It is good for humanity as well. It can be good for your family as well. It can be good to have a doctor in the family. It could be useful to people. And I think it's also a good, respectable, noble profession. So these are the plus points. Yes. And I'm not here to say what is right and wrong. I'm here to say the facts so people understand clearly that you're in it for the long run, and the education is going to take a long, long time. And the other thing is, you should enjoy what you do. Make your vocation your vacation. If you are a person who wants quick results, if you are a person, who wants to, like, one of those people who follows those things like fire movement, financially independent, retire early, or you have these targets that you want to finish this in 2 years or 4 years or 5 years, then I don't think medicine is kind of the thing for you.
Yeah.
So just a word of advice. Again, I'm not here to say what's right and wrong, but it is setting the tone for what is to be expected, because it's a long journey.
Sure. So now we've talked about the timelines, we've talked about how long it should take, and so on and so forth. Now, talking about practicing, so once you've completed your education,
Yeah.
The differences you found as a physician, as a consultant in UK and in India, working environment, the conditions that you may face, and so what are the differences?
Okay.
Or the key differences?
So thank you, sir. That's an interesting question. I think, again, different countries have different systems and advantages. In India, I think I would put it this way, that the care can be excellent. There's a lot of variation in how a condition may be treated and the type of care that you receive in different hospitals. In India, you have government hospitals and you have private hospitals. In general, the government hospitals, when people get training, they get to see a large volume of patients. There sometimes will be good infrastructure, but in the more urban parts, sometimes in the more rural parts, there may not be as excellent infrastructure and technological facilities, although this is improving a lot, because in India they are growing and there's having good investment and good infrastructure development under the excellent leadership. So, things are improving a lot. So yes, in government hospitals, there's a large volume of cases. One may come across while in their training some rare, interesting cases, and the sheer numbers or volumes of patients are large. And sometimes they may have mentors or, head of departments or teachers who are very experienced and educated and can teach them hands-on various things. In the private hospitals, they have DNB exams, and then in the private hospitals, the infrastructure can be excellent. In terms of learning, the number of cases may be a little bit less, but again, because of the MD and DNB being equivalent, it doesn't matter. Even if people work in and they do DNB in private hospitals, or even if they do their post-graduation or medicine in hospitals that have less volume of cases in India, they can always gather more experience and work in some other hospitals where they are exposed to different kinds of patients or a larger volume of patients. So I think it depends on the individual, aptitude and their willingness to learn and adapt. For example, when I studied medicine, this is like going 15, 18 years back, I never thought I'll be sitting here in London and giving this talk to other colleagues or aspiring doctors, talking to them about career guidance. I never thought about that. But, it is when you are interested in pursuing excellence and, you're interested in acquiring knowledge, the quest of that sometimes leads to certain journeys and destinations.
Absolutely.
And you can't plan all of these things.
No. So how does that differ from working in UK?
Correct. So working in UK, it's more pathway and protocol driven. I would say that in all the hospitals, 90 to 92% of care for any condition is quite similar. You would not find a huge difference in the treatment for a condition, whether in London or in Midlands or in Wales or in Scotland. You expect more than 90-92% to be similar. There are some subtle variations that occur. On the NHS, the care is very standardized. There are pretty much, national levels of models, pathways like, Royal College Physician guidance. The surgeons have their own Royal College of Surgical guidance. Again, the anesthetists have their own guidance. The obstetricians and gynecologists, they have their own guidance. So these pathways are pretty standardized. And again, in private healthcare, it's a little bit different. In the private healthcare, things can be customized to patients to suit their needs. But one of the good things, I mean, about the UK private medical care also, while practicing, is that there are various insurance. The difference is in India, usually the private medical insurance patients are those who go for inpatient care. It generally, to the best of my knowledge, it doesn't cover too many outpatient consultations, although this is changing because, there are various new policies and things are changing. I'm speaking about when I practiced there a long time ago. But in UK, a lot of the private medical practice we do as outpatients is for insured patients. They say that roughly in London, about 80% is insured and 20% is self-pay. For rest of England, 90% is insured, 10% is self-pay. So one of the advantages of doing private practice here is that because the insurance companies are sending patients, they do data analysis of every consultant and they have their algorithms to assess. So in a way it is good, because if anyone is doing things which are not very much in the guidance or framework, or there's a subtle deviation, then the insurance company algorithm will probably, refer less patients to that consultant or take them off their list of preferred consultants. So in a way that is good for the patient and for the society as well, because if someone is over investigating, it becomes a disincentive from the insurance company. That is in a way good. I mean, I haven't practiced in other countries like America, but I'm told that this is what I've been told by colleagues who have worked in different parts, that the UK practice is actually quite good and regulated, because the insurance companies have their own pathways, and they try to do their data analysis of a particular consultant, surgeon or physician to see the number of tests and their outcomes that they have compared to other peers of the specialty. So that's my experience. The private healthcare can be customized. Like we discussed, the NHS care is pretty standardized. And again, I think the main difference is this, that in Western countries, like say in England, you can see a NHS consultant, the waiting lists have gone up significantly.
Absolutely.
Prior to the COVID pandemic in 2020, the waiting lists were in control and it was a reasonable period of few months. And the aim was to see most patients within 18 weeks of their referral. But unfortunately, now that is not really being achieved.
That's right. Wow. Okay. Now, let's come to your experience now. Okay. As in, so what is your role as a teacher for younger students? Like you mentioned, you have quite a few students under your care. And as a private practitioner, how do you balance it? What does it look like for you?
So I think, training and educating the next generation of doctors, I think, this is something which is very important. I think it's important to do this, because I think ultimately our aim is we have to make sure the next generation of doctors is well equipped, they are compassionate, they have good technical skills, and it's our duty to do our best to help them develop these skills. Of course, we cannot do it for them, but we have to guide them, give them the correct guidance and be there to facilitate this. They have to clear exams by themselves, they have to develop competencies themselves, but they require good mentorship and guidance. And I'm fortunate and blessed to say that I've had some of the best mentoring consultants in India, in Mumbai, which I'm very grateful to. And I've also had some of the best mentoring consultants, in England and in London as well. So a good mix of them. And, I'm always grateful. I never forget that. And I also feel that, I also have a role to shape the career of the next generation of doctors. And I always do my best to educate them. If I see an interesting case, I always try to motivate them to read about it so that they don't forget about it. And, always we guide them. As part of being a consultant on the NHS, yes, we are generally required to be an educational and clinical supervisor. So I do have resident doctors under, working in our hospital and in our department, for which, I do have some oversight of their training to make sure that, they are having appropriate competencies as required for their progression in their training, and make sure that they are doing all their assessments that should be done. And as a supervisor, if they have any concerns, they are allowed to escalate it to me, and I do my best to resolve those or make sure that they are getting the training opportunities that they need. One thing I'd like to say is that it's one of the advantages of work. Difference I've seen in England versus India is that the educational training of the resident doctors is quite well provided for, and it's well met, in the sense that resident doctors have a lot of rights. And that can be a good thing, because I speak about as someone who's done my specialization in India. Back in those days, we didn't have too many rights. Like, we had to, and it's just an observation. There is no pun intended. It's an observation. There was a very hierarchical system, and I was happy to follow it, but there's a hierarchical system, and we would do like we were told by the seniors and by the consultants, and we would have a lot more hierarchical structured system. Whereas over here, there's not so much of a defined hierarchy, if that makes sense. Things can be a little bit less structured, and the resident doctors have their rights, like they have protected time delivered by the hospital and the university, which is meant for their training. They have formal study leave, like they are meant to have certain number of teaching sessions delivered per month, which they are compulsory attendance. They have certain number of days granted for study leave. They have certain study leave, certain number of days granted to appear for an exam, and a few days to prepare for it as well. And the university, in most of the universities and deaneries, do provide some budget to the resident doctors as well, so that they can attend some courses to develop their career and appear for some exams which are important for their career progression. So these are good things. I did not observe these back in India, but that was obviously a long time ago. And coming back to your question, so I enjoy private practice. I think it's good to have NHS practice and private practice. I think the both of them are different. I like private practice because it, you customize the care to suit the patient's need. It's about being a good listener. A lot of the time, these patients have, they waited a long time to see a specialist.
True.
They want to be listened to. They want to see someone who's an experienced consultant face to face, someone who can, listen to them, address their concerns, and then give them a customized treatment plan that works for them. And, they just sometimes want to be heard out. They want to be examined. They get their diagnostic tests done, have a clear diagnosis, and the treatment started in a speedy way. And we can often give them a customized treatment plan. So, I enjoy private practice just like I enjoy NHS practice. I think one of the things that makes me happy is to reach a correct diagnosis and to help someone become healthier in a quick fashion. Of course,
that's the ultimate goal, right?
That's the ultimate goal. We can't do it all the time. I wish we could. But, there are some diagnoses and some conditions that are not curable. Those which are, obviously, our aim is to cure it and treat it. Those which cannot be cured, our aim is to slow down its progression and treat it. And unfortunately, occasionally, some conditions are like progressive, which can't be cured. But the aim is to always treat everyone with a smile and try our best to slow down the progression of any condition and make every patient happier and healthier.
Okay. Now, two things here now. The introduction of technology is not the right word, but the evolving changes that you're seeing now in technology, all of that coming in, concern me being non-clinical. Is that in any way, are we becoming more, or the clinicians or doctors becoming more reliant on technology? That's one. And second part, which is not so much connected but still linked to technology, is the introduction of online consultations. How do you see those?
Okay, so I think I'll come to the online consultation bit first. I think online consultations do have a role. My general preference is that physical examination and a face-to-face consultation is better whenever possible. Occasionally, if somebody wants an opinion because they live very far away or because of certain physical condition, like they've got some injury or some condition which prevents them leaving their home, then that can be done. But by and large, my advice is that a face-to-face consultation is better. It gives a better feel. It does allow for a better history taking. You can get a more detailed history because you're paying attention, the patient, and if applicable, their next of kin or family member is also paying more attention. So you get a more thorough history. You can pick up examination findings which cannot be done on the phone, whether a telephone or audiovisual consultation. Sometimes these diagnostic clues can be picked up better in person rather than on the telephone or an audiovisual platform for consultation. And often that reassurance that you give them is better in person. But of course, we are happy to do telephone consultations. But my advice is always is face-to-face consultations. We do get requests for online consultations and we do them. But this had a significant a role in the pandemic, because obviously through various stages of the COVID pandemic, pre-vaccination and even post-vaccination, when we had the wave of inpatient admissions for patients with respiratory failure from COVID being admitted, I think it was a health and safety and infection control requirement to do lots of telephone consultations to reduce the spread of infection. That made sense. Touch wood, as these concerns have now eased away, I think we have reverted over the last 1 to 2 years, by and large, to a default face-to-face consultation, unless somebody requests otherwise. So
before you go to your second part of the question, just a bit more on this. So now I see a trend in all of these new online clinics popping up. I mean, since the pandemic, there have been so many. Now, the role of those online clinics, and as a consultant, does it concern you? Does it worry you that is the governance done correctly for those online clinics? How do we assure to the patients that, as you mentioned, that physically seeing a patient is going to be definitely different than seeing them online? How do you ensure? I mean, as a consultant, are you worried about the governance? Are you worried about the compliance of those consultations?
I mean, there are various platforms. I presume, I mean, obviously, I can only speak for the places where I work. I can't speak for the places that I don't work. I'm aware of various online consultation platforms. I think most of them do require to have a robust governance mechanism, like you rightly pointed out, Zoe, because obviously the clinical governance framework is very important, as is the GDPR regulations. So yes, it is important. All those platforms should adhere them. I suppose most are. I'm aware of a lot of insurance companies, before they authorize a claim for a patient for a referral to a consultation for a consultant, they generally do a kind of digital telephone consultation. But it is my understanding, again, this is not from personal experience, it is my understanding that it is like a quick health check they do with the patient who has private medical insurance to understand what the symptoms are, and then they refer the patient. So in that case, it is basically serving as a referral pathway to a private practitioner. It is not like to treat it in that one episode. But my take is that if possible, a face-to-face consultation is always better. That is my general advice. And
going back to the first part of the question, which was the introduction of all the digital tools, the technology. Are you worried that we are becoming more reliant on the technology? So
this is a double-edged thing. I think technology is advantageous, but we should use it with reasonable limits on it and not be dependent on it and not let it override our clinical judgment in certain situations, right? I speak as a physician, as a respiratory and sleep consultant privately and on the NHS, but I'm aware of certain surgical colleagues, who use robots to do surgery, and my understanding from the evidence and data presented by them is that it is advantageous. So that can be a good thing. Another example is that, we have certain treatment algorithms done, like for example, when you screen for cancer, there are certain algorithms used to calculate the risk. So these have been developed after a lot of research on it, and AI is being used to also like screen for certain symptoms and give you a possible diagnosis. A lot of patients, to be honest with me, as a consultant, I do see this change because, for example, I come across a lot of patients who come to me saying that my smartwatch has detected that my sleep is poor and I'm snoring and my oxygen level is dropping in the sleep. Could you test me for sleep apnea? Now, I never got patients on the NHS or privately coming to me like this 8 years ago, right? This has changed. So there is a role. So what I tell them is that, okay, your smartwatch, whether it's your Fitbit or Apple Watch, is not medically validated for this. We'll have to do a medically validated test like a sleep study to confirm if you have sleep apnea or not. I appreciate the concerns you said, but we have to use a medically validated test. Again, AI, there is a role for it. Like, for example, in screening for cancers, it has a role in robot-assisted surgery. My surgical colleagues will tell you more, especially the specialty surgeons who are using it in their practice. And also, like I speak about this, there is something called electromagnetic bronchoscopy or navigational bronchoscopy, which helps a pulmonologist or chest physician reach the small nodules or the peripheral lesions in the lung. So there is a role of it, and yes, but one shouldn't be over dependent on these things, because at the end of the day, I think the human judgment of a skilled, experienced practitioner is quite important. And if I look at it, my concern is that I'm slightly concerned when I see, for example, I sometimes see the next generation of doctors looking at CT scans before they see an X-ray. And I always tell them, please look at the X-ray first. Compare the chest X-ray to the old chest X-ray. Yes, you open the CT scan. Don't look at the CT scan before seeing the patient and examining them. All right? Go in a logical way. Take the history, examination findings, then look at the X-ray, compare it to the old X-rays, and then look at the scan from a learning point of view. All right. Because if one goes straight away to looking at the CT scans without examining the patient or without taking a thorough history, then I think that's not good medicine, and it won't help develop the same skills that, the other generation acquired. So there is a role of AI. I think there is no point in trying to say that wherever possible, we should take advantage of the AI delivered improvements, like in robotic surgery, like in screening for cancer, like in certain type of endoscopies like navigational bronchoscopy or electromagnetic bronchoscopy. But it's important to have an experienced consultant who is available to make the right decisions. Compassionate care, explaining something, breaking bad news, or counseling somebody about the lifestyle changes required, or explaining the diagnosis, what are the disease modifiable, lifestyle changes, risk factors which can be done. These things I don't think a robot can do as well. And I don't think any device like Alexa or any chat GTP can do, because I sometimes have patients who have come and they come across occasionally and they say that this is what the symptoms I had, I've researched this online, and this is
I'll
what,
own up to that, I've done something
correct,
similar.
and this is what it says is the diagnosis. So I mean, I don't dismiss it. I do listen as a private practitioner, but I take my own history, I do my examination and my findings, and then I listen to what they have to say. So I think it's important to embrace technology, but it's also important not to let it take control of the whole diagnostic process. Medicine is an art. All right, it's an art of science and on a balance of probabilities. It's not something that is a black and white thing that 1 + 1 is 2 or 90 + 10 is 100. But it is a science based on the experience, guidance, and evidence-based skills. And we should follow to these things. And I think it's always important to learn that. I think I've had some great mentors in in India and in England as well. And I think what I would say is that they were all excellent clinicians, right? I think it is easier to develop, it's easier to learn to adjust your practice to the advances in technology. Like for example, if CT scanners or different types of diagnostic tests come into play a few years down the line, it is easier to learn about them and be skilled. But it is more difficult for a next generation doctor to learn clinical medicine if they have become less skilled in that because they've been too reliant on technology. Because that I'll phrase it in this particular way, because I've had some great mentors, and I think when I was a resident doctor in India, I think one of my mentors told me, like I mean, I'm very fortunate, like I've worked with some of the best doctors, and I worked under the guidance of Dr. Farooq Udwadia. I would say he's a legendary one of the most legendary doctors I've ever seen, and a great man. And he was practicing in Breach Candy Hospital in Mumbai at the age of 84, probably one of the sharpest minds in medicine that I have ever seen, and maybe the sharpest mind that I will ever see in my life. But he used to tell us that it's quite easy to learn how to interpret diagnostic tests, but most of the next generation are actually lacking the clinical skills that are required. For example, one might know how to interpret a CT scan, but when one examines the tummy, some doctors may not be able to appreciate and feel the small spleen or the small liver. right? Which is just mildly enlarged. And that comes with experience and good clinical skills. If these skills are not up to the mark, then I don't think the artificial intelligence can substitute that. But on the other hand, if someone is a good clinician or a good surgeon, in their field, yes, if they are a good surgeon, they can make advantage of the advancements that come about.
Fantastic. Now, we've touched upon quite a few things. Now, going back to the young aspiring doctors, final words of advice, any suggestions, recommendations? What would you say to somebody who's becoming, whether in UK, whether in India, anywhere in the world, what would your advice be? You have had 18 years of career. Prior to that, you've been in education for 10, 12 years in medicine. So what would your advice be?
My advice is that, being a doctor is a good thing for society. You're doing some good to people. And if you want to do medicine, do it because you like it, genuinely like it, or get a bit of work experience, understand what it is. It's a long journey. When you do a career like medicine, you do it because you're passionate and you like it. You don't do it because you are following the trend or because somebody else has told you to do it. You understand maturely that it's a long journey. Like we discussed, it's going to be 12 to 13 years to be a specialist. That is assuming you don't do research, you don't take a career break, etc. The rewards will come late. I think your rewards in this are from, having a kind of good social platform. You learn a lot in medicine. Sometimes it teaches you humility when you see that, life can change in a matter of days for individuals. It allows you to understand that, things can change in life. And you understand that, you understand the value of things in life. It also gives you a good sense of responsibility, because when you study medicine for such a long period, I think, you get good technical skills and knowledge. But the important thing to succeed is to be a good human being, be positive, have a smile on your face. And I think sometimes, having that smile or the way that you communicate, it can leave a positive impact on your patients. And I think that's important. Like, I think, when you wake up every morning, you should feel positive about your career choice. It's a long journey. Believe me, it's not going to be something that finishes in few years. So my word of advice is that, medicine is a good, noble profession. When you do medicine, you do it to seek excellence and to acquire good clinical knowledge, procedural skills if you're a surgeon or physicians as well. And you do it with a view to improving everyone's health. And you don't have any expectations in terms of, don't compare it to your colleagues or your peers who are studying other careers like, say architecture, law or finance. Don't compare it with them, because they will start working and earning much before you, and their education is a lot shorter. So my suggestion is, don't compare it to them. They've chosen a different pathway. Be friends with them, interact with them, but don't think that your journey is going to be like them. You are in this for the long term. It can be a noble thing to be a doctor. If you are aspiring to be a doctor, always remember, I think, try to be positive. Let that positive vibe, go to your patients as well, and try your best as far as possible to be a good clinician. Embrace the role of technology or AI, but don't be over reliant on these things. That's my word of advice. I think no one system is perfect. There's no thing that, medicine in India or medicine in England is perfect. It's like whether do you like biryani or do you like pasta? Both are good. There's no right and wrong answer. All right. Each has its pros and cons. Studying medicine in England is also good. Like I said, it is standardized. People have more rights as a resident doctor. But of course, there are a lot of costs as well in studying over here as well. And sometimes, there are various factors to consider.
Okay. So I think we'll close by saying something you said earlier on. The ultimate goal is a positive clinical outcome for your patients.
Yes.
And that's the most rewarding thing.
Absolutely. And I think when I wake up every day, my aim is that, whichever outpatient or inpatient I see, my aim is genuinely to try and reach a diagnosis to improve their health in the quickest possible way with the least number of tests. I mean, that's my aim, and I feel happy about doing that. And I think
whatever the specialty,
correct,
whatever the level you're at.
That's my simple goal.
Yeah. Okay. So thank you very much once again, Dr. Anand.
You're welcome.
Thank you very much. If any one of you would like to reach Dr. Anand, have any questions, links for Dr. Anand's LinkedIn will be in the description. Follow him. Any questions, please put them in the comments. As always, thank you very much for listening. Thank you very much, Dr. Anand. It's been a pleasure.
Thank you.
And we'll hope to see you soon. We've tried to fit, the elephant in a small box within an hour. It's a huge subject. It's a huge topic. We could talk hours on it. If we need to, we will invite you again to discuss any other topic, maybe extend the current topic. But for now, anything you would like to say for closing?
No, I would say thank you to Zoeb, and thank you to Social Untold for calling me again. It's an honor. And like I say, you never know what journeys you take in life. Sitting 15 years ago, I never thought I would be sitting here giving a educational, motivational talk to doctors across from India and England about their career development. But I'm very happy and honored to be doing it, because I think it is our responsibility to give some career guidance to the next generation of doctors. And I do want to play a significant role in, educating and mentoring them. And, I'm also pleased to say that I did mentor some candidates giving the European Diploma in Adult Respiratory Medicine. I did, as a consultant, I do mentoring for the doctors who work in our department as well, as an official role as a supervisor. And previously also, I've been privileged to have had great mentors in my career. So I think, it works both ways. The more you give, the more you get back.
Super. Fantastic advice. Thank you very much for today. As always, please like, comment, share, subscribe. This is all for now. Thank you very much. Goodbye.